and welcome back to Yak Talk Hacking the Boards. I'm Yakov,
I'm Ben.
and today we're going to be talking about a very high yield, commonly tested topic, and that is post-MI complications. So this is episode 3 out of 3 of our series on angina and ACS. So we're going to be talking about things that can go wrong after an MI.
Yeah, and there are generally two types of questions they like to ask. You know that a topic is high yield when there's two types of questions.
Very true.
So there are the PCI and stent related complications, and then there are the structural and inflammatory complications. And we're going to get into some questions about both.
Yep. So let's just dive into our first question. So Ben, let's say we have a 68-year-old man. He is literally made out of cigarettes.
I'm sorry, he's made out of cigarettes?
He's made out of cigarettes. He smokes so much that he's made out of cigarettes.
Right,
And
okay, I accept it.
and he comes in with intermittent chest pressure at rest over the past 12 hours. EKG shows T-wave inversions. A cath shows 90% LAD occlusion, and he gets a stent placed. But overnight, his blood pressure tanks to 80 over 50s, and his heart rate jumps to the 120s. You do an EKG, it's showing ST elevations in V1 through V4. So Ben, what do you think's going on here?
So it sounds like to me he's having a stent thrombosis.
Okay. And what is a stent thrombosis and what's the pathophysiology there?
Right. So a stent is a piece of foreign object that the body sees as such, and therefore it is thrombogenic, meaning it's going to predispose that artery to have a thrombus formation. It's going to occlude, and it sounds like in this case, it's occluded so much that he's essentially now, instead of the Stemi picture that he came in with, has upgraded to a Stemi sort of picture with these ST elevations and a complete occlusion, it sounds like, and even some cardiogenic shock with his blood pressure and his heart rate doing what they're doing.
Absolutely. So not a pretty picture for this patient, unfortunately. And what's another risk factor? Let's say he had been sent home, did fine during his hospitalization, but 10 days or so after being home, he was discharged with dual antiplatelet therapy and told to take them. What if this happened while at home? What would you think of?
Yeah, I would think of kind of unfortunately medication non-adherence or non-compliance, which are terms we're trying to move away from. And the questions that I've seen with that, they'll usually mention something like the patient is uninsured or homeless. They'll give a factor that puts them at risk for medication, difficulty taking that medication.
Perfect. So why don't we move on to the next question?
Great. So speaking of stents still, we have a 68-year-old female who is hospitalized for STEMI. On day 3 of hospitalization, she complains of abdominal pain and skin changes. Derm exam shows lacy mottled skin on her legs, as well as bluish discoloration of her digits. Her creatinine is up from 1.1 and it's now 2.3. EKG shows only Q waves. So tell me, Yak, what's this skin finding all about?
Yeah, so this comes up in questions all the time. And this bluish discoloration and the lacy mottled skin is pretty classic for something called levato reticularis, which is something that you could see post-stent that's due to the release of cholesterol emboli through the systemic circulation. So you could think of a stent as opening up a previously stenotic coronary artery. And with that, you could sometimes release cholesterol emboli that can deposit in tissues and cause this levato reticularis finding. It can also deposit in arterioles throughout the body as well.
So that's exactly what I was going to ask you about next. We're already seeing an acute kidney injury here, as well as dermatological changes. What are some other possible manifestations of cholesterol emboli?
Right. Yeah. So just like you said, it can deposit in the arterioles that feed the kidneys. It can cause bowel ischemia for the same reason. You can even get GI bleeds from these cholesterol emboli, and it can also cause pancreatitis. Let's say now, Ben, we have a 73-year-old female hospitalized after a STEMI due to a complete occlusion of the RCA. They're day 3 post PCI and stent placement. So what are 2 structural complications we worry about at this point, given that it's been about anywhere from 3 to 5 days post MI and her obstruction was in the RCA?
So given, right, that it's right-sided, the 2 structural complications we would worry about would be a papillary muscle rupture, because that's going to be supplied by the RCA, as well as an interventricular septal rupture.
Perfect. Um, and can these only happen at 3 to 5 days, or can they also happen acutely?
They can also happen acutely. Yeah.
Perfect. Okay, so next best test if we're worried about these.
As we mentioned earlier, an echo.
Perfect. So now let's talk about each of them. So with papillary muscle rupture, what are two major physical exam findings you would look for?
So for that, you would have a new holosystolic murmur, as well as the physical exam findings that go along with pulmonary edema. So, basilar or even further up, crackles.
Exactly. And that makes sense, right? Because papillary muscles normally supply tension to the mitral valve. If you lose those papillary muscles, all of a sudden it's as if you have no mitral valve. So blood will back up and do what it does. And then moving on to the interventricular septal rupture, how will that most likely present?
So the overall clinical picture is probably going to look like shock.
Hmm. Hmm. And what are some classic physical exam findings, as well as kind of a special O2 measurement that tends to come up in board questions?
Yep, they do love that. So the new physical exam finding is also a holosystolic murmur. So of note, that's not really going to help between these two pathologies we're talking about. But you will see more oxygen in the right ventricle than the right atrium, which would not normally be the case. There shouldn't be any oxygen diffusion between those 2 points.
Perfect. Perfect. So let's move on to the next question.
Yeah. So now, kind of similar situation, except we have a 67-year-old male who was hospitalized after a STEMI due to LAD occlusion. So we're talking about left-sided. What are the three structural complications we have to worry about here?
Yep. So with a left-sided, just like with right-sided, you can get interventricular septal rupture. So that's a common one for both. But with left-sided, we also are additionally worried about free wall rupture and a left ventricular aneurysm. Those are specific to the left side MIs.
Great. So we've already spoken about the interventricular septal rupture, which is going to be the same for either the RCA or the LAD. What about this free wall rupture? How and also when will this present?
Yeah, so free wall rupture, it can present acutely or up to 2 weeks post PCI, post MI, and it'll present as essentially shock as well. It will appear slightly differently than our interventricular septal rupture in the sense that you'll have distant heart sounds. And on echo, you can actually see fluid in the pericardial sac, because if you think about the anatomy, if our free wall is now opened up, essentially, blood will flow out of the heart and into the pericardial space.
So now we're gonna add to the same case. It's that same patient with the LAD occlusion. Let's say they go home and he returns 2 months later with worsening fatigue and dyspnea. On exam, he has bilateral crackles, a displaced PMI with a slight systolic murmur. EKG shows deep Q waves and ST elevations in V2 through V5, which is unchanged from discharge 2 months prior. What do you think is the diagnosis? What's going on here?
Yeah, so this is more of a benign finding of the complications. It's still worrisome, but this sounds like a left ventricular aneurysm.
Yep, that is exactly what would be going on here. And what's the pathophysiology behind that development?
Yeah, so you had an initial hit to the left side of the heart with your MI. So that leads to inflammation, a weakening of the muscle, scarring, and fibrosis that ultimately leads to the aneurysm of the left ventricle.
Perfect. And do you know which lack of which treatment puts the patient at greater risk for this complication?
Yeah, so classically in test questions, the answer to this will be either that the patient never got a PCI or that the PCI was delayed. Those are like the biggest risk factors for getting a left ventricular aneurysm down the road.
Perfect. Okay. And now the last injection of information for this patient. He also has a cold and mottled left lower extremity with an absent pedal pulse. What's causing this new finding? What's the name of this?
Yeah, so this is one of the more worrisome complications of a left ventricular aneurysm. This patient seems to have acute limb ischemia. So essentially, blood likes to flow in a laminar direction, right? It doesn't like turbulence. But when you have a left ventricular aneurysm, all of a sudden your blood is turbulent in the left ventricle, and you could form what's called an intramural thrombus in the left ventricle, and subsequently shoot that thrombus anywhere in the body, including to the arteries that supply the limbs. And so, what it looks like is this left ventricular aneurysm led to a thrombus that the patient shot to his left leg.
And then lastly, on this case, how do we differentiate this, acute limb ischemia situation from a cholesterol embolism situation?
Yeah, that's an important distinction. So first of all, you wouldn't see levator reticularis with intramural thrombus, right? But you would with cholesterol emboli. But you also wouldn't really see cold extremities or absent pedal pulses if this were just cholesterol emboli. You would see that much more commonly in thrombus.
Perfect. Okay. And now on to our last case.
Yeah. So our last case, let's say we have a 64-year-old gentleman coming in with chest pain, worse with deep breathing and better with leaning forward. And 2 weeks ago, he was hospitalized for MI and he thinks he's having another one. EKG shows ST elevations in all the leads, it's everywhere. So, what type of chest pain is this and why does that matter?
So it's you said the chest pain is worse with deep breathing,
Mm-hmm.
better with leaning forward. So that sounds to me like pleuritic chest pain.
Mm-hmm.
And I guess the reason that that would be important is because there's kind of a different differential than your typical, mid-sternal kind of anginal type pain.
Perfect. And so, given the timing of and quality of these symptoms, what's the likely diagnosis?
So I'm thinking that this is Dressler's because, it's in that classic like 2 to 6 week period after the MI that it's popping up.
Perfect. And can you describe Dressler syndrome and what the pathophysiology is there?
Yeah, so it's essentially that you have the original insult of the MI, and then unfortunately your immune system recognizes some of these sequestered antigens, and there's an autoimmune antibody formation process that occurs. And so then you get this delayed autoimmune pericarditis picture.
Perfect. Yep. And that pericarditis is what explains those ST elevations everywhere on the EKG. And lastly, how do we treat it?
NSAIDs,
Yep.
just NSAIDs, which is
Good.
slightly different from normal pericarditis. What's the other thing that they like to add on to your normal pericarditis treatment?
Yeah, classical and test questions, it'll be NSAID plus colchicine.
Yeah.
But for Dressler's, good old Advil will do the trick.
Don't you love that?
Mm-hmm. Well,
Anyways, thanks for tuning in, everybody. It's been a pleasure to have you for this 3-part episode series.
and we'll see you next time.